Hello everyone. So this is a new topic, heart disease in pregnancy. So we are going to take a look at signs, symptoms, classification, management of heart disease during pregnancy and labor. So first let's have an overview of what it entails. Heart disease in pregnancy is a significant risk factor contributing to maternal and fetal morbidity and mortality. The most common cardiac lesion encountered in pregnancy is of rheumatic origin, followed by congenital lesions. The physiological changes in pregnancy, including increased blood flow, blood volume, cardiac output, and hormonal effects, exacerbate the underlying heart conditions, necessitating careful monitoring and management. So, all of this is self-explanatory. I don't have to go further into the details. Coming to what is actually required, signs and symptoms. So, first one. I'll go through this first. Pregnant woman with heart disease. So in this particular question, we are looking at grade 2. There are multiple grades. So grade 2. This is what we are looking at. Let's see what grade 2 is first. Slight limitation of physical activity, comfortable at rest, but ordinary physical activity causes discomfort. Typically presents with symptoms exacerbated by pregnancy-induced hemodynamic changes. Should we go through it first? Pregnancy induced, just a summary. We'll just go through the summary of what pregnancy or what this includes. So heart is displaced, that one we know. We have systolic murmur and then continuous humming murmur. Look at it. And ECG axis deviation. On cardiac output we have how much? We have 30 to 50% increase. Blood pressure increases. SVR decreases. Venous pressure increases, and there is supine hypotension syndrome, and there is also regional blood flow changes. So overall these are things: cardiac output increased by 40%, systolic volume increased by 27, which means contracting much stronger, heart rate increased by 17, venous pressure increased by 100, SVR less, it reduces, PVR reduces, and colloidal osmotic reduces. So looking at this, it is obvious that we need to have a special focus on heart diseases in pregnancy. Yes, now coming back, now main topic, yes. Breathlessness, fatigue, palpitation, chest pain, nocturnal cough, syncope or dizziness, peripheral edema. So let's see what the reasoning is. Breathlessness, especially on exertion, what the description is. Fatigue disproportionate to the level of activity due to palpitation due to increased heart rate and cardiac workload, chest pain particularly in cases of ischemic heart disease, nocturnal cough and an early sign of left heart failure, syncope due to reduced cardiac reserve leading to syncope, peripheral edema secondary to volume overload. So all of these things make sense. So again, breathlessness, fatigue, palpitation, chest pain, nocturnal cough, syncope or dizziness, peripheral edema. Coming to the classification of heart disease, so we have NYHA classification. We have learned this in medicine, but we are going to repeat it again. So grade 1, uncompromised, no symptoms with physical activity, and grade 4, which is the maximum one, symptoms present at rest, severe limitation of physical activity is seen. So this one is the least, this one is the maximum. Let's see what's there in the middle. Grade 2, slight limitation of physical activity, comfortable at rest, but ordinary physical activity causes discomfort. This is what the question is all about. Grade 3, marked limitation of physical activity, comfortable only at rest. But in this particular case, even the rest is a mess. It's painful. It is not painful, it is symptomatic. Patients with grade 2 heart disease can usually tolerate pregnancy with proper management, but require close supervision to prevent deterioration. Now coming to the management during pregnancy. It requires multidisciplinary approach including obstetrician, cardiologist and anesthetist, and the principles include, we have antenatal care and then management during labor and under different stages of labor. Now coming to antenatal care, yes, there is risk stratification. Identify risk factors for cardiac disease, such as cardiac failure, such as anemia, hypertension, infections, and arrhythmias, comorbidities. Regular monitoring, serial echo to assess left ventricular function, frequent assessment of NYHA classification, watch for early signs of decompensation. So, serial echocardiography to assess left ventricular function, frequent assessment of NYHA classification, and watch for early signs of decompensation. So, these are the things for regular monitoring. Next, coming to the medications. So, this one, I think in medicine we have this. Yeah, medicine, this is a very important topic, heart failure. So, same things mentioned over here. So, first one, number 1, anticoagulation. Low molecular weight heparin is preferred over warfarin. So, for patients with prosthetic valves or atrial fibrillation. Diuretics for volume overload. Caution is needed to prevent excessive volume depletion. So, diuretics for volume overload, caution is needed to prevent volume depletion. Beta blockers for arrhythmia control and afterload reduction. Anemia control and afterload reduction. Arrhythmia, not anemia, arrhythmia. Sorry, did I say anemia? That is the problem with recording. Like, you can't just pause it and go back and check. And even in real life, it's the same thing. Anyways, digoxin for symptomatic relief in heart failure, iron and folic acid supplementation to prevent anemia induced cardiac decompensation. So, again, anticoagulation, low molecular weight heparin, which is better than warfarin. This is for patients with prosthetic valve or atrial fibrillation, because we know more tendency of thrombus being formed. Diuretics for volume overload, but make sure that we don't lose excess of fluid. Beta blockers for arrhythmia control after load reduction, digoxin for symptomatic relief, IFA to prevent anemia. Coming to lifestyle modification, rest and restricted activity to avoid excessive workload on heart. Dietary sodium restriction to avoid fluid overload and avoidance of teratogenic drugs in early pregnancy. Therapeutic termination in cases where maternal risk is high, like Eisenmenger syndrome, severe pulmonary hypertension, termination before 12 weeks is recommended. So, these things. So, what is this? This one we have studied in pediatrics, and also I think it would be taken in medicine. It is there in medicine too, wherein reversal of shunt that happens in congenital heart defects. So, instead of left to right, it becomes right to left, leading to cyanosis and severe pulmonary hypertension, and this one is the precursor of Eisenmenger. So, we need to terminate before 12 weeks. Coming to management during labor. So, labor presents severe hemodynamic stress, several significant stress, hence following measures are crucial. First stage, second stage, third stage, and postpartum stage, which is the fourth stage. Coming to first stage, positioning left lateral to minimize aortocaval compression. Left lateral position. Coming to oxygen therapy, 5 to 6 liters per minute as required. 5 to 6 liters per minute as required. Pain control, epidural anesthesia preferred to reduce cardiac overload. Prophylactic antibiotics prevent infective endocarditis. Fluid restriction less than 75 ml per hour to avoid pulmonary edema, and continuous cardiac monitoring to detect arrhythmias and hypoxia. So, again, positioning left lateral, oxygen therapy 5 to 6 liters per minute, pain control, epidural anesthesia to reduce overload, cardiac overload, workload, prophylactic antibiotics to prevent infective endocarditis, fluid resuscitation 75 ml, less than that 75 ml per hour, continuous cardiac monitoring to detect arrhythmias and hypoxia. Second stage, shortened second stage, use forceps or vacuum assisted delivery to avoid maternal straining. Avoidance of ergometrin causes coronary artery spasm. Oxytocin infusion is preferred. So, this one we have seen the reasoning why, because this one is mostly systemic ergometrin, but this one is localized to the uterus. Coming to digitalization, if necessary, IV digoxin 0.5 milligram in patients with rapid ventricular rate. IV digoxin. Third stage, control cord clamping. Yeah, this one is this one, right? Oh, what is it? Brant Andrews. Is it mentioned here? Yeah. Control active management. prevent sudden preload changes by early control cord clamping, oxytocin infusion 10 international units IM to manage uterine atony without causing hypotension, 10 international units to manage uterine atony, and blood loss monitoring, transfusion if hemoglobin falls below critical levels. Let us just see if AMTSL is followed. Is AMTSL followed in heart disease grade 2? It is avoided. Yeah, it is avoided in this one, sudden volume shift. So we don't want heart to get overloaded. So that's what I was thinking. Risk of tachycardia, hypertension due to uterotonics. So we need to manage it. So even here it is mentioned. See, oxytocin, where was it? Yeah, without causing hypotension. So 10 units to manage. It is just to manage the uterine atony. We cannot give as much as we want. Modified. There is modified AMTSL. Avoid ergometrin. So slow IV infusion instead of bolus. Control contraction carefully and closely monitor heart failure signs. So that is modified AMTSL, which is used in this particular case, grade 2 heart failure, grade 2 heart disease. Coming to postpartum care, monitor for heart failure. First 24 to 48 hours are critical. Oxygen and diuretics for those with pulmonary congestion. Early ambulation, reduce thromboembolic risk. Anticoagulation therapy, restart if indicated for prosthetic valves. Anticoagulation therapy. Contraceptive counseling, barrier methods are preferred. Progestin only pills for those requiring contraception, and avoid estrogen based contraceptives for due to thrombotic risk. So contraceptive counseling, barrier methods, progestin only pills, and avoid estrogen based contraceptives due to thrombotic risk. And that was about the, what was it? Yeah, heart disease in pregnancy. Yes. So we have this is the end of the video. So in case you like this particular discussion, you can like this. In case you would like to watch more of such videos, you can subscribe. And then bye bye.